In this PowerPoint, we will look at an introductory overview of the opioids classification. Looking at the term opioids, this is a general umbrella term that includes all forms in this classification: natural, semi-synthetic, fully synthetic, and endogenous forms. The term opiates is also widely used and is specifically attached to the natural and semi-synthetic forms, as they are derived at least partially from opium. The term opioids is used as an umbrella term as each form produces similar effects. These general effects include activation of the opioid receptors in the brain. There are three natural opioid receptors, mu, kappa, and delta, and they work to help us modulate pain, our response to pain, and some pleasure responses. Lastly, opioids act directly on the respiratory center, causing a slowdown in this area. This is one of the reasons why opioid overdose can be so dangerous. Taking a look at the medical uses of opioids, opioids have been utilized across cultures for thousands of years. Early medical and ritual use viewed opioids as miraculous in their healing potential. While there are a range of medical uses, several are emphasized. First, they are widely used for pain relief and the treatment of chronic pain. One of the reasons is that they help not only diminish the sense of pain, but also diminish a person's awareness of it. This is therapeutic benefit, as pain can result in shock and anxiety, and opioids work to help a person remain calm as well as be in less pain. Second, opioids have regularly been used as a cough suppressant. And third, opioids have been effective in many regions of the world as a treatment for diarrhea and dysentery. These are vital to treat, as without proper treatment for these issues, they can actually lead to severe and life-threatening complications. Taking a closer look at the main forms of opioids that help in these medical uses, we will start first with the natural types. There are three natural types which are derived from the alkaloids in the poppy plant. These three are morphine, which was discovered in 1806. This is the most potent of the three and is often considered to be the gold standard for pain relief. Next is codeine, which was discovered in 1832, and lastly thebaine, the weakest of the three alkaloids, which was discovered in 1835. Looking more closely at morphine, after its discovery in 1806, use spread significantly due to two developments: the hypodermic syringe, which made it more available to physicians, and its regular use during the Civil War for treatment of pain commonly referred to as soldier's disease. It is important to note that during that time, little about the addiction potential was known, which has become a common theme with this classification. However, as the addiction potential became known and acknowledged, this led to a search to find a way to harness the pain-relieving properties from the poppy plant while eliminating the habit-forming addiction potential. This effort is what has fueled the search and development of many of the following forms. Moving next to semi and synthetic opioids, the most known of the semi-synthetic forms is generally heroin. Semi-synthetic means that one of the three natural alkaloids is used in the manufacturing process. Heroin has morphine with the combination of acetyl groups added. Currently known mostly as a street drug form, it has a history as a medication. Its chemical name is diacetylmorphine and was given the brand name heroin by Bayer and placed on the market in 1898 as a non-habit-forming alternative to morphine. It was later discovered to be actually 3 times as potent as morphine. While the United States lists heroin and diacetylmorphine as a Schedule I substance, other countries still have it available by prescription. Two common types of fully synthetic, meaning completely manufactured, are Demerol, which was formulated in 1932, and methadone in 1939. Here again, we see the quest to find a non-addictive opioid, as methadone was first believed to be a non-habit-forming alternative to morphine. It was originally prescribed as an alternative to those with a morphine allergy and has become known for its use in treating opioid addiction. Since its development, a more in-depth understanding of its uses as well as the addiction potential is now understood. When discussing semi and synthetic forms, prescription opioids fall under both of these categories. Listed on this slide are some examples of both semi-synthetic and fully synthetic. Lastly, designer drugs and new psychoactive substances in this classification is extensive. Some examples would include crocodile or crocodile, acetylfentanyl, and purple drink. Currently, there continues to be rapid expansion increases in the different types and forms of designer drugs and new psychoactive substances for this classification, all coming with strong alerts and warnings due to high toxicity concerns. But as noted earlier in the semester, please keep in mind that many of these trends are not actually new per se, as the active ingredient in crocodile has been around since the early 1900s, and purple drink has been widely used in other locations for decades. When discussing opioids, it is impossible not to discuss social issues and concerns related to what is considered to be the most current wave or most recent epidemic use of opioids in the United States. On both a local and national level, opioid addiction and overdoses are viewed as developing at an alarming rate. When looking at local concerns, it is often hard to grapple with the significant rise in both of these. It was back in 2006 where a total of 4 deaths were attributed to heroin locally. That is a very different picture to the explosion in increasing percentages that we currently have. While the understanding of how use trend increased so quickly is now routinely documented, it can be worthwhile to review some of the key points. Several factors occurred close together, fueling the current epidemic. The first was the availability of prescription opioids. Prescription opioids began to be available and easily accessible for pain-related medical conditions. While many people started taking them for legitimate pain reasons and as prescribed, this started to shift. A growing number began taking them not as prescribed, and in addition, adolescents were finding these medications available in their parents' medicine cabinet, and use in that population escalated as well. The second related factor was public perception. There was not enough accurate and up-to-date information regarding these medications. Many thought, well, it has to be okay if it's being prescribed, or addiction is unlikely to develop. When this was believed to be inaccurate information, often prescribers would stop prescribing. But this did not stop use. Instead, it frequently led to alternative attempts, in particular purchasing the medication illegally, however, at an expensive rate. This cost issue then influenced what is believed to be the third contributing factor, as those struggling with a serious opioid addiction began seeking a way to sustain use more cheaply. So a second type of supply was ready and waiting: heroin. During this time, heroin production in several areas in the world skyrocketed, and the supply was waiting and available. In addition, it was purer than had been in a long time and cheap. Therefore, those struggling made the leap from prescription opioids to heroin. Not far after, increased production in designer drugs, new psychoactive substances also started to escalate. So due to this increase in purity and the revolving door of new deadlier designer drug combinations being sold, the risk of opioid overdose also began to skyrocket. Another key social issue and concern relates to treatment. With the rise in opioid use, treatment centers were not equipped to deal with those needing services. While attempts at increasing the amount and range of treatment options, increasing funding for treatment, and reducing barriers to services continues, locally and nationally there remain a significant shortage in services, especially for those with limited financial resources or in rural or diverse community settings. In particular, many diverse communities have been speaking out regarding the lack of attention to the opioid epidemic in their communities, as well as the lack of quality and effective treatment options available to successfully meet their needs. This last social issue has actually led to positive change responses from within communities. Many grassroots initiatives and leaders have emerged both locally and nationally to highlight cultural factors that need to be included when discussing the current opioid epidemic and its impact. In addition, community-based and creative strategies to address disparities, expand treatment options, and create culturally responsive treatment strategies are now receiving long overdue and much needed attention. Taking a step back to understand why these concerns have received so much local and national attention, a little more discussion on the short and long-term effects of opioids is needed. With both of these types of effects, health concerns and risks are prevalent. While there are many short-term and long-term effects, the following have specifically generated social concerns. Starting first with the short-term effects and risks, a common effect in this classification is referred to as a biphasic response. This means that there is an initial pleasure and or euphoric effect followed by a drowsy response, often labeled as nodding. In addition, a reduced respiration rate and clouding of mental functioning occur. Taken together, this can be very risky and dangerous behaviorally, as reports of nodding off while driving continue to occur. Likewise, physiological risk in the form of acute toxicity is of epidemic concern, namely in the form of opioid overdose potential. The depression of respiration is what leads to overdose deaths, and this effect of opioids are compounded when combined with the depressant classification, such as alcohol. When addressing opioid overdose, we look for what is referred to as the opioid triad: coma, depressed respiration, and pinpoint pupils. In these circumstances, medical attention is imperative. The medication used to counteract an overdose is naloxone or Narcan, and has been effectively used in saving many, many lives. Turning now to long-term effects of social concern, one of the most common risks and effects discussed is addiction potential. Opioids hold a high risk of addiction in both physical and psychological areas. This is an issue in the field that receives ongoing discussion and examination, as the risks of addiction potential for this classification are now well known. Also, much attention has been given to opioid withdrawal syndrome. What is currently known regarding this issue is that withdrawal symptoms from opioids are often extremely horrible and often result in people relapsing due to not being able to withstand the withdrawal experience. What is also commonly understood about opioid withdrawal symptoms is that they are not considered to be life-threatening or lethal on their own. However, while it is believed that one cannot die from the withdrawal symptoms themselves, caution needs to be taken for those who are medically at risk or who have medical complications. In these situations, the experience of the withdrawal symptoms can be too distressing for the body and can result in serious life-threatening complications and consequences. However, again, this is when medical concerns and complications exist. The withdrawal symptoms alone are not currently considered to be lethal. A more detailed look at the withdrawal process is shown in this slide and in the text. This will provide you with a breakdown of the specific signs and symptoms that can occur, especially in the first 72 hours.